Thank you, and thanks for having me today. I'm going to present some of the findings from some interviews that we did last year with clients. I'll get straight into it, so nothing to disclose. So in Australia, we've had some research indicate that we do need to increase testing if we're going to reach the elimination targets that were set out by the WHO by 2030. But as no surprise to, I think, most people here, we know that people at greatest risk of infection, primarily people who inject drugs, often experience barriers to testing, and that might be patient-level barriers such as poor venous access, stigma and discrimination from healthcare services, but also service-level barriers such as lack of on-site phlebotomy. In Australia, we're pretty lucky. We've had the scale-up of alternative testing technologies, dry blood spot and point-of-care testing. And this is great because they should have less barriers to care, particularly among people at risk of infection. But although they have been scaled up quite a lot lately, there has been limited research regarding their acceptability, particularly among people who inject drugs. So that's the premise of this research, to sort of evaluate the acceptability among clients of different testing models with a focus on dry blood spot and point-of-care testing. So we conducted semi-structured interviews with participants from the Australian Hepatitis C point-of-care testing program, and clients were needed to have a history of hepatitis C testing, at least once, any type. The interview guide addressed demographics, experiences of DBS testing or point-of-care testing, the role of peers in testing and results delivery, and different methods to potentially scale up hepatitis C testing in Australia. The interviews were coded, de-identified, and analysed using iterative categorisation. And to provide a framework for acceptability for this research, we used SECON's theoretical framework of acceptability, just to provide some further context to the findings. So I'll sort of go through some of the constructs in a second. Although there are 7 constructs for SECON's theoretical framework of acceptability, most of our interview data focused on 4 of them. So burden, ethicality, intervention coherence, and self-efficacy. So I'll go through those in a second and explain sort of the differences there. All right, so we interviewed 40 participants last year with a median age of 47 years. 43% were female and 23% were Aboriginal or Torres Strait Islander. More than half of our participants had current injection drug use, and many of the others had a history of injecting drug use. And 68% had previously been infected with hepatitis C. We had representation from most Australian states or territories. And then importantly, with regards to the participants' experiences of dry blood spot and point-of-care testing, the majority only had experience with DBS testing for hepatitis C. 8 had completed both DBS and point-of-care testing. 8 had completed point-of-care testing only, and 7 had not tested with either DBS or point-of-care, so probably just venipuncture. And it was interesting having people with a range of experiences of different testing, because we could look at sort of experiential, sort of past experiences with testing, and also sort of perceived ideas of testing with different testing modalities. All right, so starting off with SECON's construct of burden. So SECON describes burden as the perceived amount of effort that is required to participate in the intervention. And for this study, we categorised burden as the emotional burden or anxiety that some participants described when waiting for test results. Overall, point-of-care and dry blood spot were seen to be easy by participants who had experienced these tests. But interestingly, there was an anxiety or emotional burden described when waiting for test results among participants who had not had a history of treatment with DAAs. You can see Michael here says, "You don't want to wait, especially when I'm an anxious person. I reckon that's terrible waiting for a test, especially when you've shared needles." So this was a sentiment described by participants who maybe were treated with interferon and potentially had had some pretty bad side effects in the past. people who had not received treatment at all, whether or not they've been infected with hepatitis C, but either way, these are participants who had not had DAA treatment in the past. This could suggest that these participants were unaware of the simplicity of DAA treatments or the ability to access treatments without restrictions in Australia. And this was compared to participants who had experienced DAAs before. Among these participants, understandably, there was a very strong preference for having same-day test results. So this was usually associated with point-of-care testing, as opposed to dry blood spot or venipuncture that can take 1 to 2 weeks for test results. Interestingly, though, this sentiment wasn't evident among people who had treatment history with DAAs. These participants found the wait time to be quite acceptable for DBS and venipuncture, and instead had other preferences or values that were more important to them. So they described importance of time required to spend at the clinic, or the availability of incentives, or potentially the location of the clinic. So you see Benjamin here says, when I asked him if it was important to get his results back on the same day, he says, not really, it depends on what same day means. I mean, I don't want to hang around all day. If it's going to mean one less visit, yeah, but if it doesn't bother me that much. The results come through when they come through. So it was quite an interesting sort of juxtaposition between people with a history of DAAs and those without, and how that might have impacted this concept of burden. All right, moving on to SECON's constructive ethicality, and this one will echo a lot of what we've already heard in this session. So SECON describes it as the extent to which the intervention has good fit with an individual's value system. And unsurprisingly, maybe we linked this to participants' experiences of stigma and discrimination, and also their beliefs on peer support, particularly for hepatitis C care. Somewhat surprisingly, many participants were unclear on the definition of a peer worker or whether they had experienced peer support for hepatitis C before. This was interesting because most of our participants had been recruited from a peer-based organisation, but many had described experiences, sort of their friendships, their peers, or maybe experience with peer support groups such as AA. Among those that were aware, and once we described peer support specifically for hepatitis C, there was general acceptability for peer workers to be involved, both in Hep C testing and results delivery. And this was particularly true if they were attending an unknown service, sort of they were unsure about what they might face at a service. It was comforting to know that there would be a peer there to support them through that process. You can see Brooke here, you've probably read it already, but she says, I don't have a preference. I think it's good to have it done by a peer. Doctors don't often have an understanding. It's just easier to talk to a peer without judgment. And I think this is also something that we've just heard as well, but the idea that peer support is fantastic, and I'm a strong advocate for it, but that the provision of non-judgmental care is maybe just as important in some settings, and particularly in a setting where the person has a trusted service that they go to, a trusted engagement, that non-judgmental care there is really key. Also, many participants identified that peer support was not a one-size-fits-all approach, and that the individual needs of the person may differ based on what they are looking for or what they need at that time in their life. There's here whether they need a motherly figure, a peer at a similar age to them, or maybe it's a situation, so only a peer when they're receiving positive results as opposed to getting their negative test result. I won't read through that one, I'm hoping you've read it already. All right, so intervention coherence. So SECON here describes it as the extent to which the participant understands the intervention and how it works. Most participants did not have a preference if their finger prick test was done by a peer or a nurse, and that was due to the perceived simplicity of the test. Again, particularly true if it was at a service that they already visit, a service where they have a trusted relationship. Josh says it wouldn't matter as long as they know what they're doing. But this did not extend, again, probably unsurprisingly, to venipuncture, and people required really highly trained healthcare professionals due to their poor venous access and their experiences in the past with trying to receive venipuncture. It was also somewhat surprising, so also related to intervention coherence, that some people had a misunderstanding about their Hep C status following a cure. And this one we looked into quite a bit because some participants who had previously cured their Hep C, whether it was through treatment or spontaneous clearance, continued to come back for testing regularly despite not declaring any sort of at-risk behaviours or transmission events. May have been still happening, but it did pop up quite a lot in the interviews. So you can see Jackie here says, I did actually get tested again to make sure everything's okay. I don't share or anything like that, but yeah, so continuing to test whether it's uncertainty about whether the Hep C cure has remained, and maybe this was linked to antibody status, but I think some further research into that is needed. And finally, on to self-efficacy. So SECON describes self-efficacy as the participant's confidence that they can perform the behaviour required to participate in the intervention. I found this one really interesting. So many participants, or maybe not many, some participants were not confident in completing a self-collected hepatitis C test or using sort of a mail service like you can use for dry blood spot, and preferred assisted collection at a healthcare service. So James said, I go into the needle exchange at least once a month or so anyway, so if I needed to do another finger prick test, I would probably just go through them. Almost all participants identified difficulties in providing blood samples through traditional venipuncture, again due to poor venous access, and strongly preferred finger prick collection, no surprises. This was despite some people identifying some pain or discomfort during the collection. So Jade says, I had to squeeze my finger for a while to get the blood out. Yeah, we had to keep squeezing and squeezing. She said, your pinky is going to be bruised by the time we're finished. So by applying SECON's theoretical framework of acceptability, these results have highlighted some remaining service gaps that we still need to bridge if we are to scale up hepatitis C testing and if we are to achieve elimination. With relation to burden, there is a need for improved education on the availability and tolerability of direct-acting antivirals, and probably a need for improved access to rapid point-of-care testing to reduce that emotional burden. Regarding ethicality, we need to continue to advocate for non-judgmental care and the use of peer navigators with a range of backgrounds to ensure that we're supporting people where they're at and the time of life that they're in. With relation to intervention coherence, there's a need to improve education on Hep C risk factors and testing, particularly following cure, and ensure that healthcare providers are providing information to their clients as well about that. And regarding self-efficacy, there's a need for further research into the acceptability of Hep C self-testing, particularly among people who inject drugs. These study findings are going to be really key in identifying what's the best test to use in the best environment with the right person, and to ensure that Hep C testing and linkage to care continues. I think it will also be important to inform national and global testing policies, such as the WHO self-testing guidelines for hepatitis C. So in conclusion, it's really important that we look at some of these remaining gaps if we are to achieve elimination in Australia and globally, and to ensure that clients can receive testing without stigma and discrimination. It'll be critical that people at risk of infection are offered different testing options in different settings. And important, of course, to say that both dry blood spot and point of care were highly acceptable among people at risk of infection, but there are further nuances that we need to address when we're developing educational, clinical and policy frameworks, and to consider when we're scaling up testing in different settings. I just want to thank all of the participants for their time and their very valuable insights when speaking with me, and every single participating site in the national program for all of your findings as well. Thank you.
Thank you.
Thank you, and I hope this study will help us, activists, prove that peer involvement is very useful and it gives results. It's been very interesting listening to you, and also we who have the experience of using or buying drugs know that there is another reason we are really it's very difficult for us to wait, because we've waited days and nights and hours sick to buy drugs. So maybe you should add this reason too.
Thank you.
Okay, thank you very much once again.